Esteemed guests, please welcome Dr. Linda P. Freed.
Well, good afternoon, everyone, and welcome to this year's World Leaders Forum addressing global health security and preparedness. This topic becomes especially salient as we approach the historic anniversary of the UN Security Council resolution on the Ebola outbreak in West Africa in 2014. The goal of today's forum is to assess current global preparedness, specifically in response to the recent set of recommendations laid out by the World Health Organization and World Bank in the wake of the 74th session of the UN General Assembly. Today, you will hear remarks and discussions from prominent leaders in the field of global health security. We will begin with a keynote address, followed by a moderated discussion with our panel, who will be introduced shortly by Professor Wilmot James. After the panel, we will have a 30-minute question and answer session, and of course, I encourage the audience, all of you, to ask questions and comment about what you've heard today. I'm really deeply honored today's keynote speaker, Dr. Gro Harlem Brundtland, an esteemed global leader, member of the Elders, former Prime Minister of Norway, and former Director General of the World Health Organization. A physician with public health training, Dr. Brundtland has dedicated her life and professional career to promoting health as a human right, achieving health for all, and is a champion in the realm of sustainable development. Dr. Brundtland served as both Director General of the World Health Organization from 1998 to 2003, and before that, she was the Prime Minister of Norway, both the youngest and the first female Prime Minister, where her tenure there has been looked to as providing immensely strong leadership in the fight for women's rights, world peace, and environment protection. During her tenured term at the World Health Organization, she was a global leader in many fights and transformative accomplishments, from her efforts to create the historic Framework Convention on Tobacco Control to her real dramatic and efficient response to the SARS virus outbreak, without which it is clear large-scale prevention might not have been possible. From 2007 to 2010, she served as a UN Special Envoy on climate change. Dr. Brundtland currently serves as a member of the Elders, an independent organization founded by Nelson Mandela and consisting of the world's most distinguished leaders using their collective experience and influence for peace, justice, and human rights. Through her work with the Elders, Dr. Brundtland has used her decades of leadership in public health, medicine, and politics to call for leadership commitments to control climate change, for gender equality, universal health coverage, and an end to severe absolute poverty. Dr. Brundtland exemplifies, from my point of view, the term courageous leadership, and is individuals such as herself who are at the forefront of making enormous strides on the road to a healthier, more equitable world for all. And with that, it is my honor to cede the podium to Dr. Brundtland.
Thank you so much for that enormous introduction. You know, you realize how long your life has been when you hear all of that. Ladies and gentlemen, it is a great honor to be here with you today to discuss such an important and timely topic. As the leaders of the world are gathered here in New York City for the United Nations General Assembly, the issue of global health security should be uppermost in their minds. I am speaking today as a medical doctor and someone who has spent decades in public life at a national and international level. I'm also speaking as member of the Elders, the group of independent global leaders founded by Nelson Mandela to work for peace, justice, and human rights. When preparing for this speech, I was reminded of a powerful quote from Mandela that should underpin all our deliberations. Health cannot be a question of income, it is a fundamental human right. By the same token, all global citizens have the right to live in peace and security, and it is the responsibility of politicians and health professionals to ensure that health security is maintained in an inclusive, fair, and transparent fashion. As a former Prime Minister and Director General of World Health Organization, I know the enormous constraints, too, faced by politicians, including the perpetual challenge of budgetary restraints and competing agendas. But I also know that leaders have to take bold action in the interests of their people and the wider world, and the centrality of political will to taking hard decisions that can be literally a matter of life and death. We do live in an age where a global security emergency that would endanger tens of millions of lives could be imminent. In days, a lethal influenza pandemic could spread across the world, halting trade and travel, while creating widespread social chaos and leaving a hole in the economy, the global economy. We can see today in the Democratic Republic of Congo how a lack of health security infrastructure, the result of decades of conflict and weak governance, exacerbates the impact of the Ebola epidemic to deadly effect. Without a doubt, Ebola is a catastrophe for the victims of the disease, their families, their wider communities, and the countries and regions that are affected. The way to avert this and future catastrophes is to invest in health security capability. And at its most fundamental level, this means investing in and promoting universal health coverage, so all members of society, from the richest to the poorest and most vulnerable, have access to the health care they need without falling into poverty. Yesterday, I spoke at the high-level meeting on universal health coverage convened by the President of the UN General Assembly. And the Secretary General was there, speaking very eloquently and very directly about the issues. My message there was the same as it is today. Unless leaders get serious about achieving universal health coverage, the world will never enjoy genuine or sustainable health security. This means governments must take proactive steps to publicly fund healthcare with a deliberate focus on preventive measures and primary healthcare, so vulnerable and marginalized groups are being covered. Last month, I visited South Africa with my fellow elder, the former president of Chile, Ricardo Lagos, to learn more about the government plans to introduce national health insurance to support their efforts to cover all South Africans. The reforms proposed by President Ramaphosa and his government are timely, they are ambitious and affordable. Indeed, if implemented successfully, they could offer a model to the United States, where, like in South Africa, the health system is dominated and distorted by inefficient and inequitable private health insurance schemes. We know that weak governance, infrastructure, and the lack of trust between people and their health services impede efforts to fight diseases that are already identified and can be contained and overcome. Countries that are already suffering other forms of fragility are the most at risk. This is as true today as it was 100 years ago, when an outbreak of we call Spanish influenza, killed more people than had died in the First World War, in part because that conflict had devastated public health and infrastructure across Europe. Meanwhile, today, we see the world's worst outbreak of cholera in war-ravaged Yemen, where hospitals are deliberately targeted by military forces in contravention of the Geneva Conventions and the rules of war. But it is dangerously complacent to assume that health security is a concern only for the conflict-riven countries. A new report by the Global Preparedness Monitoring Board, of which I am co-chair, together with my esteemed colleague Assi of the International Federation of the Red Cross and Red Crescent Societies, we warn that humankind is stumbling towards the 21st century equivalent of the 1918 influenza pandemic. It could happen. We need to be prepared when it happens. In 1918, though, a virus could not travel the world in just over a day. Today, local epidemics can quickly become regional and global. Combined with increasingly complex social challenges, including the eroding trust in institutions and the deliberate spread of misinformation, particularly via social media, this becomes a question not of if, but when a deadly outbreak emerges and threatens to become a global pandemic. Now, this doomsday scenario need not be inevitable. We have developed many of the tools needed to prepare for an outbreak, but world leaders are not scaling them up. In the report that we launched on this Sunday, we had to say there are alarming gaps and they need to be filled. We have where life-saving health technologies, including vaccines, drugs, and diagnostics, are lacking, investment is needed to ensure that these are developed and that the communities that need them most do get them. Health systems need to be managed efficiently and transparently. They must be fully integrated into the global health and governance architecture. In this regard, there is much that we learned from the experience of the SARS epidemic of 2002 and 2003, when I ran the WHO. This was a sudden outbreak of a new disease. It took a few weeks to identify the new virus, and then some months to contain it. International organizations faced particular challenges in balancing the imperative of clear and precise public messages with the political reality of engaging with particular regimes with an embedded culture of secrecy and authoritarian control. But successful international collaboration between governments, health organizations, and scientists meant it was possible to both understand and contain this disease, and ultimately prevent what could have become an international health disaster. Now, one of the lessons that the WHO drew from that experience was that transparency and open communication is absolutely vital. First and foremost, to report and identify disease, and then to be able to issue global alerts and, when necessary, travel screening measures. An essential factor, undoubtedly, at that time in 2003, was the clarity of the WHO Constitution itself, made by our earlier leaders in 47, 48. The authority and the respect for leadership in global health that Constitution gave us. I could point to that Constitution when people were questioning the authority of WHO to make recommendations. Nobody else could. Not a single government. Nobody would be in charge to give the world advice about what to do. But we could, and I did. An essential factor was that, and the respect for leadership that it turned out that was given to us. We managed to assert authority and won respect among the world's governments, as well as other key international institutions and stakeholders. In fact, the poor health minister of China was forced to resign because he was the person in charge of not responding, not reporting, not answering my calls, etc. And why? He was afraid of his leadership in China. But then the leadership understood that the world is watching. They know what has been going on, that we have been, non-responding to something that became an international catastrophe. And they took a woman, vice president of China. She became the health minister. She was vice president, but she took on the portfolio of health minister and came to Geneva in May and turned around, the face of China. So it was a learning experience for many, I can tell you. Now, the WHO and its partners have also in many ways significantly improved their response capability since the 2014-16 West African Ebola outbreak, including the use of breakthrough vaccines, medicines, and innovative technologies. Yet the current outbreak in the DRC is taking place in a far more complex environment, where communities suffer from severe and long-standing insecurity and lack of trust in authorities and in healthcare workers. Understanding community needs and ensuring that they are fully engaged in planning and accountability mechanisms is essential. Solutions can no longer be solely focused on health. They must involve all parts of society, including the security sector. Heads of governments need to do much more to protect the health security of their people. So in the report I mentioned from Sunday, we are addressing directly government leaders. They are responsible, not the poor health ministers. There is a significant weakness in all countries' defenses when it comes to epidemic preparedness. The reality of our networked world is that we are only as strong as our weakest link. In cost terms, investing in preparedness is excellent value for money as well. The same logic indeed applies to universal health coverage, which is the surest way of strengthening all the links in the global health security chain. Investment in health also means investment in the economy as a whole. This was the conclusion of the Commission on Macroeconomics and Health that I established as Director General of the World Health Organization in 2000, led by Professor Jeffrey Sachs. In fact, not investing in health is the very definition of a faltering economy. A Lancet Commission chaired by the Harvard economist Larry Summers has recently estimated that the economic returns to investing in health will be at least 10 times the outlay of public spending. These findings have been endorsed by over 350 of the world's leading economists. Nevertheless, given the scale of existing challenges, there is some understandable skepticism within governments about the relevance and importance of preparing for acts of bioterrorism that might take place in the future. When resources are scarce, they would rather address the health issues that their countries are already coping with today. The need to deal with the conventional challenges that already exist, as well as emerging threats, must be borne in mind as we seek ways to bring different international and local actors together to address the real challenges in health security. Yet, there can be a win-win approach. Resilience to epidemics and deliberate biological threats must be firmly rooted in the health system, a system that is fit for purpose for the challenges it faces every day. States should meet this responsibility to their citizens by fully implementing the international health regulations and providing sufficient public funds to ensure universal health coverage. This will improve the resilience of individuals' health, of the system of health infrastructure and delivery, and crucially, the trust between citizens and the state. Data from the World Bank and WHO show that most countries would only need to spend, on average, between $1 and $2 per person per year to reach an acceptable level of health emergency preparedness, representing a return on investment of 10 to 1 or higher. Now, obviously, wealthier countries should also invest more to fill the gaps. The alarming gaps that I mentioned are there, and we need to be showing solidarity enough for lower income countries, because ultimately the world is fully interconnected and threats to one are threats to all. We need to assert this spirit of solidarity if we are to enhance the capabilities of the global health security system and avert a catastrophe. This means upholding and strengthening the principles of multilateralism and a rules-based international system to better withstand the threats of isolationism and the politics of cynical short-term horizons. Diseases know no borders and cannot be kept at bay by walls or barbed wire fences. So it would be truly catastrophic if our vision of security becomes so distorted by the discourse of bellicose nationalism that it dehumanizes people seeking shelter on the shores of prosperous states. Separating families and keeping children in cages is not the hallmark of a civilized society, nor is it the hallmark of a healthy society. If refugees, migrants, and other marginalized and vulnerable groups are left in squalid and dangerous conditions, from the Rio Grande to Cox's Bazar in Bangladesh, the health security of all of our societies will be threatened. To conclude, we need to recognize the scale of the challenge facing all of us. It can be tackled with innovation, ingenuity, and investment, deploying technological advancements to improve the resilience of health systems and health security infrastructure. But ultimately, of course, we will only deliver health security for all if we understand it as a matter of human rights and dignity, drawing on the legacy of ethical leaders like Nelson Mandela to build a better, safer, healthier world for our children and grandchildren. Thank you. Stephen. I'm going over there.
Thank you very much. Ladies and gentlemen, my name is Walmart James. I'm a visiting professor at Columbia University in pediatrics and political science. And I'd like to thank Dean Fried for welcoming, and in particular thank Dr. Brundtland for a superb address. During the month of August, the New York Times opined the fact that there was very little global leadership when it comes to health security. Well, I think they didn't look carefully enough, because clearly, as you've heard from Dr. Brundtland, is a superb leader when it comes to global health, and I'd like to give her a second round of applause for an excellent address. So, ladies and gentlemen, to engage with the presentation, we have a very distinguished panel of three, and I'd like to introduce them to you and invite them to join us at the front. First of all, Dr. Ernest Monitz, who is an emeritus professor from MIT and a presidential advisor to the Massachusetts Institute of Technology. And as you know, he's a nuclear physicist by background. He's the former US Secretary of Energy to President Obama. He's currently the co-chairman and chief executive officer of the Nuclear Threat Initiative, whose purpose is to do three things. First, to secure nuclear materials globally. Secondly, to build international cooperation for nuclear disarmament and non-proliferation. And third, to reduce radiological and biological risks in the world. So welcome, Dr. Monitz. My second guest is Dr. Nila Muluk, who is a physician and ophthalmologist. She's been Minister of Health of Indonesia since the 27th of October, 2014. She's also the Indonesia's Sherpa for the network of global leaders in various events dedicated to initiatives to improve women's and children's lives in developing countries. And she's been a foremost leader of the global health security agenda, both globally and from the part of the world that she is here. So welcome, Dr. Muluk. So I come from South Africa, and Dr. Muluk comes from Indonesia, and we share a language, which is a language of colonization, which is Dutch. Just to tell you, there's a connection there. Our third speaker is Dr. Chikwe Ihikwezu. He is a medical and public health specialist. He's the director of the Nigerian Center for Disease Control. There was a fabulous piece published in Nature magazine and also in the Financial Times describing the fact that 2 years into his appointment, he doubled his staff. He's a steward of multi-million-dollar grants. He's battled 12 outbreaks affecting 70,000 people. And his quote describing what he was doing is that we are building, he said, a ship while it's sailing. He had to deal with yellow fever, meningitis, cholera, Lassa fever, polio, and monkeypox. So welcome, Dr. Ihikwezu. I am now going to invite the panelists to respond to Dr. Brundtland but in the response to also tell us, in the first instance, a question directed to Dr. Monitz as the first respondent, to tell us, while he responds, what in his view are the greatest global health security threats we face now and in the future. And before you respond, Dr. Monitz, I'm going to do something that's not very royal. I'm now going to walk to my seat in front of you. So if you let me do that, thank you very much.
Well, thank you, Wilmot. I'll certainly make a few remarks. First, on what we just heard from Gro, and there were a lot of themes covered there, and also respond to this issue in terms of threats. First of all, I think it's clear. I think we would all endorse Gro's focus on the need for the overall health system to be sound and to be comprehensive in order to allow us the foundations for a strong health and biosecurity program. I would also emphasize, and this actually I think is one of the threats, it's not the biological threat per se, but the fact that in the end, if we are responding to an event, a pandemic, an outbreak, the Ebola example from some years back, we have to recognize that the health system must be sound, but we also need a tremendous degree of cross-sectoral activity. And I think at NTI, we did a tabletop at the Munich Security Conference. Gro was a participant in that at a distance, but it brought out the fact that particularly in the case of an event going on, things like the national security people must be involved. There are not established processes for working with the public health officials, with the humanitarian responders. We also have to remember that it's not only about human health, it's the agricultural system, for example. So there are so many different factors, and I think, regrettably, and I think it was implicit in your statement in terms of the level at which we have leaders discussing or perhaps not discussing these issues, that's the level at which these threads must get pulled together, and it's not nearly adequate what we see today. And I think the recommendations you made in your report, I think, point the way to at least rectifying some of that in terms of response. In particular, it's hard to see in the end how the response works without some degree of leadership from the United Nations and the Secretary General to pull all of these threads and countries together. Another point I would just emphasize, and it was referred to again by Gro in her opening remarks, is the critical role of financing. And on that, and I'm sure with Wilmot we're going to get back to that in quite some detail, but what I want to emphasize is that for the financing to work, in my view, ultimately, we must have recognition and acceptance of the idea of health security, of biosecurity, as a collective responsibility. We have seen with recent events, these are not confined by borders, and therefore it's an investment, let's say, in a developing country's health system is an investment in our own security, and we need to really have that as I think, a guiding star. Finally, in going to this issue of threats, others here who are especially trained in the medical field can say more about the spread of dangerous organisms and the like. But I just want to highlight one additional feature, which is something that does motivate us at NTI Bio quite strongly, and that is, while completely recognizing the major opportunities and benefits from the advances in biology that we are seeing, CRISPR and synthetic biology and go on, the reality is there is also an additional risk vector opened up. in terms of engineered organisms, which, for example, could be engineered to evade current responses that we have to various organisms, is another very, very important feature. And that's one, to circle back to my earlier comment, that is one that is an engineered organism outbreak, is one that would especially test our ability to manage cross-sectoral responses. So those are at least a few opening comments.
Thank you very much, Dr. Moniz. Dr. Moniz reminds us of the fact that the risk domains when it comes to catastrophic events in the world is not confined to infectious disease outbreaks and biological risks, but also nuclear, radiological, climate-related, chemical, and environmental, and that we need to think about that together. He's also right to highlight towards the end the fact that there are new technologies, and in the high end of biology, there are innovations taking place that allows us to, in fact, high-end scientists to manipulate the genetic material of pathogens, and that we need to provide protective systems around that. So thank you very much for that.
Wilma, I'll just add that my job description, the description concisely is existential threats.
Right. If I can now turn to Dr. Neela Muluk and ask her to respond, and in a response, tell us about the role of Indonesia, how she sees the role and leadership role of Indonesia in tackling the question of catastrophic outbreaks.
Yes, I think talking about the related to the global health security, as Excellency Brundtland said, it is a very crucial as now emerging and re-emerging diseases threats nowadays can spread faster and more unpredictable than ever before. I think I want to give our experience in Indonesia, because if we look at for example, the outbreak of the Ebola, I think besides many fatalities, outbreak also impact the economy and the several different ways. And quite similar situation happened in Indonesia during the outbreak of the avian influenza H5N1 in 2003, which is one of the emergency events saving our system of emergency preparedness and responses. I think it's all started when H5N1 virus infected poultry in Indonesia. The first poultry to human transmission occurred. And then for the responding to this outbreak, Indonesia has strengthened preparedness for the avian influenza and other emerging infectious diseases, such as development of public health emergency operation center and surveillance, rapid response team, and referral hospital system for emerging infectious diseases, laboratory diagnostic capacity, risk communication, and live birth market surveillance, and One Health approach in zoonosis control. That's, after that, the government initially made the committee for the zoonosis committee in 2010. But after that, we needed strengthening the regulation, and then Indonesia make it the implementing monitoring and evaluation of the capacity of international health regulation 2005. And then we, through self-party annual assessment report and joint external evaluation, Indonesia has been voluntarily assessed by GEE in 2017 for 19 technical areas related to prevention, detection, response, and other related hazards, including point entry of, and the result assessment on the 63%. Then after that, we are very active participating in the global health security agenda. Thank you.
Thank you very much to Dr. Muluk. For those of you who do not understand the details of what happens with the global health security agenda, is that a national assessment is done, and then countries have to develop a national action plan, and that national action plan has to be financed and then implemented. Indonesia has been a leader in this respect in terms of covering all the risk domains, and hosted the ministerial meetings last year. And Dr. Muluk was, of course, the host for that meeting. So thank you very much for describing exactly what happens in Indonesia. It's a model in terms of what needs to be done, and countries can do well to emulate that. If I can now turn to Dr. Chikwe Ihikwezu, and I'd like to ask him to also respond, of course, to Dr. Brundtland, but to speak to us about Nigeria. There is a one-line description of what happens in Africa is that the burden of infectious disease, including emerging infectious disease outbreaks, is the greatest, but the levels of preparedness is the weakest globally. And therefore, he is sitting in Nigeria with the Nigerian CDC, a pathfinder, and also a leader in terms of creating systems in an environment of high risk. Dr. Ikwezu.
Thank you. Thanks, Wimot, and really honored to be part of this panel. And thank you, Dr. Brundtland, for your very powerful depiction of providing a historical context for us in terms of the story of health security, and especially your terms that we're only as strong as our weakest link is kind of in contrast with the major messages coming out of the other side of town today. But global health security you also say that global health security should be on all our leaders' minds. And this is something that I push very hard in our own context, to kind of lift it up the political agenda of our leaders in Nigeria. It's very hard because of all the competing demands of resources in countries like ours, from security to infrastructure to providing just the basics for citizens. And if you ask citizens what they want, health security doesn't really rise up the agenda. So we have to advocate for health security and develop the credibility to do so efficiently. And one thing I found is in our quest for universal health coverage and the health security agenda and asking for resources, and we haven't always been as explicit on where exactly those resources should go to and what exactly should they support in developing. Yes, we do our joint external evaluations and develop our national action plans, but to pull all of that together, we really need institutions with the expertise to deliver on each of the component resources. You shared a very interesting story of the health minister in China post-SARS. And one of the biggest stories out of that epidemic, which maybe isn't recognized as broadly as it should, is the development of the China CDC. I visited the China CDC about a year ago. It's about an hour outside Beijing, and they literally have evolved from the era you described to now having, an amazing campus of thousands of scientists working on these issues day to day and developing the science on all the component bits of this broad agenda we call health security. So really, that's what we're trying to do in Nigeria. But we've since realized that there are no magic bullets. To develop the expertise that you require for health security is a journey. It's a long journey, especially in our context, where we don't necessarily have the background, the scientific background from early education to develop into the scientific capacity you need. But now we need to leapfrog a lot of these steps in order to protect ourselves and the world. So I'd like by ending in saying specifically we need to define specific interventions where we can learn from others in terms of how we can accelerate our journeys. And I truly think that in national public health institutes that bring together all the component parts that we have pushed post-Ebola, whether it's EOCs or labs or surveillance systems or risk communication, if all of that is not part of an organization with a clear mandate on health security, I'm not sure any of these individual components will lead us as quickly down the path of health security as we want to go. So I think my key lesson out of this is building on the great work that you did, the authority of WHO, the IHR, and regulations, and how we've implemented that. Now we need to build the institutions to institutionalize the work that we're doing in the countries and enable us to work together across countries on a technical basis. One final example I'll give is we had a recent cluster of monkeypox in Nigeria. Subsequent to that, there were cases in the UK, Israel, and Singapore. Now, the IHR worked well in enabling notification of those diseases. What it did not do well was supporting the institutions of these countries to work together to share information, surveillance information, information on whole genome sequencing. We're still struggling to share that among the 4 countries involved in the same outbreak because all the cases in the other countries had all traveled through Nigeria. So I think the next step now is, in addition to the IHR, how do we enable a platform where countries can share the expertise and the science in order to make our world a safer place?
Thank you very much to Chikwe. So, ladies and gentlemen, I used to be a politician in South Africa, and let me just put on my politician's hat and say 3 things. Firstly, we have a pretty good idea of what's wrong, okay? Good idea of what the risk is. I'd like Dr. Moniz to say something about the Global Health Security Index that will be launched quite soon, about how comprehensive our understanding of what the risks are. So we know what the problem is. With the Global Health Security Agenda, the issues have been assessed and plans have been put in place. So we know what governments need to do. And usually it's a public sector response. So we know that. But here is the thing, is that the financing that came for a lot of the Global Health Security Agenda, which is a special congressional appropriation of $1 billion in 2014 out of the Obama, is up. And it has not been renewed. Certainly not at the level it should be. And so the biggest single source for taking care of financing global health security globally, in fact, no longer exists. And I can give you some more details around that. So the question is, who's going to pay for this? And middle-income countries should pay for it. Upper-income countries should certainly pay for it and probably subsidize. It's the poorer countries that won't be able to afford it. And therefore, we need to have innovative financial mechanisms and entities in place in order to make sure that the investments that we are making in preparedness, in fact, results in systems that can contain diseases where they break out at source. So I'd like to get back to Dr. Brundtland. You've heard all the comments being made. If you can respond to the comments that have been made. But specifically, I would like to press you on the question of financing. We'd love to hear more coming out of the board. And we'd like to know what the vision is for a financial model that, in fact, can take a very ambitious global enterprise, which is global health security, into something that will benefit the world as a whole.
Now, first of all, let me comment to a couple of the questions that you raised from CDC Nigeria, because it's part of, because as you say, the international health regulations, they are key. They have led to implementation and preparation in many countries for the kinds of responsibilities that are there. And the national action plans are lacking in a number of countries still. And in addition, a funding process for the one thing, countries that have made national action plans, they haven't made a plan to fund them. So they have a plan in paper. So that doesn't work. So, but what we have been saying clearly in our report now, that domestic resources have to be mobilized in every country for health, including for health security. Unless we say that clearly, we are not going to have enough public funding or funding from international institutions. If you don't have that domestic basis and that means links to the community, regional, and national level in each country, then you will not have sufficient help and support from middle income or richer countries. I want to say that very clearly. So we have made 7 points of recommendations in our first report from the monitoring board. And we have announced that in 1 year from now, we will, according to certain criteria of follow-up, we will monitor what happened from September this year until September next year, and try to have all of these institutions involved and entities involved having to show accountability or be shown not to have moved. Now, I think that's important, because one of the why did the World Health Organization and the World Bank come together to create the body that I am co-chairing? Because they were frustrated at the lack of follow-up to the very important recommendations made by the panels that were set up after the Ebola crisis, because of the obvious need for emergency preparedness. So now we have a monitoring and accountability board which can help push these issues. Now, those 7 points and recommendations and action points that we are calling for, one of them is that WHO member states must commit in the World Health Assembly in May to replenish and support the emergency fund of WHO itself to $100 million a year. Now, I can say this, and we are convinced that this is necessary. I cannot be sure that the World Health Assembly, in fact, will do so. But so we need to have voices expressing strong opinions that this, in fact, should happen in the World Health Assembly. Now, that's all the governments of the world. But the first point that we are addressing, this was not number 1, but number 1 was addressing every government leader. This is a responsibility for government leaders, because it is across society responsibility. It is not something that the health minister alone deals with. From defense to infrastructure to all parts of society, these preparations and these preparedness efforts are at the level of the leader of government. The foreign minister, the finance minister, they are all responsible. Now, so we are calling them out to take that responsibility. And the international health regulations themselves, they this is a legally binding, obligatory convention. And that is not something that is the responsibility of a single minister in a government. The government has signed up to the international health regulations. And so the agreement from 2005 shows that it is really on the desk of the leaders of countries to respond and to implement those obligations that are there in the international health regulations. Now, so this is government leaders. Then you have G77, G7, the international gatherings of leaders. They have made recommendations, even they have made commitments about what they were going to put of responsibilities to finance preparedness. And when you look at it, the follow-up has been really meager. So again, we are calling on these institutions to look at their own recommendations and to show more serious implementation and follow-up. Now, then you have the World Bank. It's important because the systems that have been in place within the World Bank of loans and grants to countries have had strong limitations on them to be able to give resources to preparedness efforts. So this, and we are calling on the World Bank, which is one of the institutions that started my monitoring board, that they have to change their own internal processes about the criteria for giving resources to countries that need them, because they have to integrate global preparedness into the development models and the systems when they work with countries. So we are also giving that recommendation to the World Bank. And we will see then within the coming months and the coming year that the World Bank follows up on this. I'm hopeful that it can help. Yeah.
Could I just add?
Yes, go.
Well, first, since you mentioned the index, I feel compelled now to say what that is. So in approximately a month, NTI Bio will be issuing the first global security index for health and bio. This is modeled after an index that's been quite successful since 2010 in nuclear preparedness. And the idea is it literally, it's done, by the way, in collaboration with Johns Hopkins School of Public Health and the Economist Intelligence Unit. And it literally will go take 195 countries with specific questions and criteria to examine. And what I want to emphasize is, and this reflects what I consider the success of the nuclear index, is that the index is constructed and aims to provide countries independent views as to where are the opportunities for improvement. That's really the focus of this, and we hope that that will be the case here as well as in the nuclear. I just can't resist adding just one other comment, and that is to go back to the financing, et cetera. As I said earlier, I believe one of the very important accomplishments we need is to really drive home the idea of collective responsibility in this context. Collective responsibility inherently raises the issue of, in my view, kind of international institutions. Regrettably, in the United States, we are in a political cycle that is not favorable towards building international institutions. So we also need to fix that, frankly.
So thank you very, very much for those comments. We now would like to give you an opportunity to pose questions. If you can indicate whether you'd like to ask a question, please tell us who you are, and also whether you'd like to direct a question to a particular speaker or panelist. Would you please go to the microphone, sir?
That will discourage them.
Yep.
Okay, thank you. Thank you very much. My name is Aksha, and I'm a student from Johns Hopkins Bloomberg School of Public Health, and now I'm also from Indonesia. So yesterday I sat on the panel with honorable ministers at the UNGA side event talking about the primary healthcare towards the SDGs and UHC. I talked with many of my other colleagues in Hopkins about the Ebola crisis, as well as any other global health threats such as antimicrobial resistance. We agree that one of the major pitfalls in identifying, containing global health outbreaks is the weakness of our primary healthcare system, because it is unprioritized, underfunded, understaffed, unskilled health workers, and uncoordinated. You know, when we have a weakness of our primary healthcare system, we cannot have a good system to counter any kind of global health threats. To all leaders, do you agree that a weak and vulnerable primary healthcare system will affect our response to any kind of global health threats? If you agree with that, how would be the best thing to do to strengthen our primary healthcare system to counter any kind of global health threats? Thank you.
Okay, that's a vast question, so, but a very good one. So thank you very much for the question, but I'm going to ask Chikwe to respond to that.
Maybe the yeah, I mean, and this is a tough question, and it really is at the heart of discussions around the continent. Dr. Brundtland spoke about her visit to South Africa, where they're grappling with the same issues we are as well. There's some big decisions to be made around how to achieve this through direct public financing or through health insurance models. There are many debates around what is the appropriate mechanism. It's also dependent a lot on where our countries are structured. We run a federal republic in Nigeria where the states have a great level of autonomy in terms of how to deliver primary health care and responsibility. So, but one thing is clear, whether it's health security or immunization or access to family planning, none of these are grandiose ideas will be possible without a functioning primary health care system. So I don't have a perfect answer other than to say that we absolutely agree, at least in Nigeria, that this has to be the foundation. And we are finding our own path to that. Too slowly for me, but that's the reality of our context. And I'm sure it's the same experience in Indonesia and in many other countries. But absolutely clear that every other thing we do has to be based on a strong primary health care system to work.
So the building blocks of a healthcare system is, in fact, to start with primary healthcare and with the concept of universal healthcare. That a benchmark has now been set and adopted by both the UN and global bodies. So that's really good progress. So does any of the other panels like to respond to that question? If not, could we have the second person?
Just over there.
Go ahead, sir.
Hi, my name is Mateo, and I'm a senior at Columbia studying biology and statistics. My question is surrounding, again, the funding aspect of these programs. I think that everyone on this panel can agree that funding for health initiatives, whether it be infectious diseases or what I'm personally interested in, non-communicable diseases and cancer specifically, should be funded. But I'd like to ask to both of you on the right, specifically, what are your struggles in convincing your own countries internally that these initiatives should be funded, and what do you think positive ways of tackling the problems of actually convincing your own leaders on how to start funding health initiatives, whether it be infectious diseases or other diseases that can contribute to increased health care in your countries?
Shall we start with you, Dr. Maluk?
Me?
Yeah.
May I have Dr. Donald?
I'm sorry.
I need the help from my colleague.
Yes.
It's okay? So
All right.
answer how the financing for the... Okay. That was it. Yeah.
Well, thank you for the question. In the context of Indonesia, I think coordination is very important amongst the sectors. And also, in the recent days, we try to implement what we call, with the assistance of the World Bank, health security assessment financing tools to determine how important the roles of each sectors, not only at the central level, but also the local level, to put some money, in the budget in terms for the epidemic preparedness. So we are still now in the pilots in some districts. We hope after this implementation of this pilot of the health security financing assessment tools, then we can determine what should be done to make it a better system for the financing to bring all sectors and central and government level. Thank you.
Thank you very much for that response. Chikwe.
Yeah, just a very small comment. I think all of us as health leaders in the health sector, I definitely have had to develop my expertise in how to advocate for resources from our political leadership. And the conventional narrative that, people are dying, save us and give us more money, we found out doesn't necessarily work. But we haven't necessarily been trained in the art of defining value in investing in health, and it's obviously a slightly more complicated argument to make than when you're soliciting for funds for infrastructure and you can show the outputs of what those funds achieve for you. So I think there's a challenge on our part to really get a little bit more sophisticated in making the arguments for more investments in health, whether it's in health security or in non-communicable disease, cancer, and the rest. One last point is we do have an opportunity with the World Bank in Nigeria at the moment through a Redise funding window that was developed across West Africa post-Ebola. And one of the biggest challenges I have had is to really clearly define the benefits of that opportunity to the country and be sure that we are articulating that as clearly as possible so that we can demonstrate the value that that has added, not just to the health sector, but to the rest of the country and the confidence of investors in the Nigerian economy. So that's really a key point in making the financial arguments. But, it's something I've learned on the job myself and was definitely not prepared for this when I started three years ago. And I doubt many of our leaders in the health sector, in Africa at least, are prepared to make those type of very difficult debates and arguments to our finance ministers.
Let me just add that, it was a really great question. Let me just add, working with the South African government, is that your average government will do what they did last year and just add a bit more money. That's what would happen. We're talking about, and Dr. Brundtland has brought up the point, we need to redesign government around global health security. And the biggest barriers are between the hard agencies and the soft ones. So defense doesn't speak to health normally. What you need to do is to integrate and redesign at the same time, and then budget on that basis. And to do that with public sector institutions is a very hard thing to do, but it can be done. So thanks for that comment. Please go ahead, sir.
Robert Yates from the Central Global Health Security at Chatham House, and to stick with this topic of financing, which is absolutely crucial, of course, and really to suggest to the panel with your thoughts on that there really is no alternative whatsoever apart from tax financing. It's the only way to really finance a health system, and we were hearing this right throughout the UN yesterday, that there is this consensus that if you're serious about universal health coverage, then tax financing is the only solution. And Chikwe, you say that the CDC in China was born out of the recent SARS epidemic, but it was also born out of the UHC reforms that sort of seen China re-socialize its health financing system and is now spending an extra 2% of GDP on its health system, and which is benefiting the whole system. And one feels that sort of countries like Nigeria and Indonesia and lots of middle-income countries, there is no alternative, either general taxation or social health insurance, which is a form of taxation, let's call it that. And then in poorer countries, they are going to need some support, but that is going to, in effect, come from tax financing from overseas. So, put it to the panel, your thoughts, that there is no alternative apart from tax financing.
So can I just comment on what Rob just said here? Is the, obviously, when I use the expressions, we need domestic input, domestic financing from every country at a certain level. There is no other way to get that domestic financing than taxation. Yeah. And every country needs to have a real taxation system. Many developing countries have been much too slow to develop that. And unless they do, they cannot have a system that works, not only for health, but for education and other things. Now, the other thing, domestic resources and public financing, that also means taxation. And so I think we shouldn't avoid addressing the reality that to have global or national public goods, you have to have a redistribution system of resources. And that means taxation in some form or type. But it has to happen. Otherwise, we are not a safe society.
So just to affirm Dr. Brundtland's point, is that health is a public good and is going to have to be financed publicly through taxation. And as a fundamentally important point. And you can have private-public partnerships, you can mobilize national resources from the private sector and from philanthropies and so on. But the fundamental, it's a responsibility of every country to do that in looking after its citizens. It's a moral responsibility.
Well, I fundamentally agree with what's been said, but just to say technically, there are other ways of raising public resources than taxes. In the end, for example, surcharges on products. It's not directly. So it's all.
That's another part
hidden.
of taxation in my mind.
So I'll give you an example to make it clear. Let me make it really clear, and you all can translate this into this sector. But let me take the energy sector, where I also do a lot of work. There are taxpayers. There are ratepayers, which is a different way of collecting the funds. There are things like, actually, the governor of New Mexico just announced that she will implement free college tuition paid for by royalties on oil and gas production. So it's always coming from someone.
I know.
But all I'm just saying is technically it's not what we normally call a tax. And that may be very important politically, because frankly, it hides where the money is coming from a little bit.
You know,
it's very technical.
I agree, but I want to mention also that when I was in Indonesia a couple of years ago, speaking with you and with the president, because the problem of making nationwide a system of primary health care and universal health coverage in your country, Indonesia, it was, how do we finance this? And one of the things that Ernesto Zedillo and I spoke with your president about was, why don't you increase or have even tobacco taxation? I mean, that's a taxation, depending on, I agree, in the argumentation of what kind of taxation, it's wise to think about different words to use. But in my mind, in real terms, these are all different types of taxes, tariffs, and public sources of money. But obviously, to tax tobacco is an important source, both to improve the health of people, to get down smoking, but also to get finances that you need to have public goods.
Yeah, tax what you don't want to happen.
Yeah, exactly. Right. Or CO2 taxes for that.
CO2 would be the same.
So let us say that, Lenny, that there's a whole regime of innovative revenue-generating public mechanisms.
Yeah.
Just to cover all of it, because, you're quite right, and we should become more innovative. The Africa Center for Disease Control wants to introduce a travel tax through African airports in order to finance its work. And this is continental, of course, it's not local. That's quite a clever idea, actually. You need to do some persuasion. But to say that we need to use existing mechanisms and we need to think hard about new, we're good at this, right? The economists should be good at this, finding new, clever, innovative mechanisms for generating funds for the public good. We've got another question.
But add to that, that I think you absolutely, that was really my point about we need other innovative, more politically palatable approaches. But in this case, there is still a second step. It's got to be distributed internationally and not just internally.
Okay.
And that's another difficult political step for the wealthier economies, at least. some wealthier, not Norway, not Norway,
no,
but
we do 1% of GDP, whatever.
I mentioned our current political cycle. That's earlier, so.
Okay. Okay, we have 10 minutes remaining. We've got 3 people who would like to pose questions. So I'm going to, we got 5. So please go ahead, ma'am.
Hi, thanks for coming. I'm Michelle. I'm a 4th-year medical student at Columbia. And my question is, as a future physician, sort of short of running for public office, what is something impactful that I can do to promote global health security?
Okay, before the panel answers, let me take the second question. If you can just go ahead.
Sure. Hi, my name is Dr. Kyle McDonald. I'm a recent graduate of the Mailman School of Public Health. My question has to do with the current political environment, which has been alluded to by several of our esteemed panelists. So considering there is a movement both here in the United States and parts of Europe and other countries focusing on a reassertion of nationalism and hard borders, what can kind of progressives or us focused on international diplomacy and multilateralism, what can we do to better advocate and demonstrate that to deal with global health security issues, we need more international collaboration and not less?
So who on the panel would like to address the question of international collaboration?
The second question?
The second question, yes.
Yeah.
Well, okay, I don't have any magic specific activity other than to say, in the end, it is about generating political accountability. If it's not viewed as accountable, it's very hard to get the kinds of commitments, especially things like the international revenue commitments that we were talking about. I'll be honest, I think that it's going to take, in this case, it's urgent, but speaking for the United States, I believe it will be a long, slow process to generate that kind of political accountability in this arena. It can happen. The greatest example that I know of, it's not in this arena, is in the environmental arena, when the first Earth Day occurred in 1970, after building up environmental insults, the people fundamentally said, enough's enough. And it actually had political accountability, and you had about 3 years of the most change in environmental law this country has ever seen. That's where you got to get to. I'm afraid I don't have a lot of specific ideas right now for doing that.
You know, I remember the time after what you just spoke about, when I was a young environment minister. And I was doing international work, of course, on behalf of Norway. The US, during those years, in the 70s, was a leading star in environmental policies, implementing laws and pushing other industrialized countries to do the same. And then sometime like 78, 79, 80, poof, you went down. And, you know, to have that experience, a dramatic change in the political atmosphere, just in front of Reagan's time here.
Actually, Nixon. It was Nixon.
No, Nixon, I mean, Nixon. Yeah. I remember how shocked I was about that real change, even within a year or two. Now, however, now that you have come so far that you are undermining the EPA and doing things that are incomprehensible to me, then, of course, this wave has gone, the pendulum has gone so far that people are going to react. I have no doubt. Maybe I am more optimistic than my American colleague here. But I believe that the American people will understand that when the president says we have the best water and the best air in the world, they know he's lying. And someday they will understand what that means.
I have to object. Yeah. I'm a physicist and therefore by nature optimistic. So I'll just add one more thing, which I think is relevant to this. In terms of building up this kind of accountability. See, I actually am optimistic that it's happening in the climate arena. and we're seeing a shift. But we're seeing a shift because I believe the public has begun to understand that climate risk is not, as dearly as we love our children and grandchildren, it's not about only future generations. It's about our generation. I think in the health arena, that is the angle. So, for example, the Ebola crisis. It was not exactly an isolated African issue, right? We had it here, right here in the United States, et cetera, et cetera. And I think that that's what we, hopefully without having to go through those kinds of pandemics, but I think it's got to get across, this is a now issue, it's a you issue, and we need to have accountability.
So thank you very much. The clinical question needs to be answered. Chikwe, would you answer that question? The question, as I recall, was what can you contribute clinically to dealing with this issue?
Okay, so I'm not sure about clinically, but I'll just say, you know, global health security sounds like a very big, vague context. We all have to remember it's national, it's local, it's individual. You know, whether it's getting your children to be vaccinated and raising your voice against the anti-vaccination campaigners, or making sure kids have access to clean drinking water to prevent diseases in our part of the world. I think we all have a small role to play in our communities, and as medical students, more than ever before, public health is a much more important part of your curriculum, I understand, than it was in my time, and definitely in the time of the more senior colleagues on the panel. So I think as we develop our expertise in the clinical areas, as clinicians or as health sector professionals generally, we must all also play a role as public health professionals and enthusiasts.
Okay, you can't see what I can see in the screen, and the screen says I must wrap up. So I will do so. But I do want to just recognize Mark Grodman, who wanted to ask a question, and he ceded the opportunity to somebody else to do that. But instead of asking a question, Mark, you have 20 seconds to make a point.
All right, 20 seconds, and now I'm down to 15. One point I do want to make is that although we talk about the importance of building infrastructure for healthcare, and although we also see that that's going to be necessary for emergency preparedness, I just don't want to leave the impression that one necessarily guarantees the other. That in fact, even in well-developed countries, and even in this country, the fact that lack of preparedness for certain emergency outbreaks can be significant, and that we really do need both, and that one does not guarantee the other. The other point, which I'm going to go take advantage of that, is to be a little bit less politically incorrect than the last question. And that is that, can there be real movement on the issues we're discussing here and on emergency preparedness without this country taking a leadership role? And what has happened over the last few years when we have not? And what would the situation be if we do not take not just one as a member of other industrialized countries, but just a leadership role to correct these problems?
So thank you very much, which then leads me, to wrap up. And I just wanted to say we recognize what the problem is. We know what needs to be done, but to just emphasize a point that was made earlier by Dr. Brundtland, we actually need to both redesign government. Governments have to be redesigned in order to deliver on this. And secondly, we've got to get really smart about financial instruments in order to pay for this. And let me say that is a wonderful conclusion to reach, even though the challenge is quite a formidable one. So I'd like to thank Dr. Brundtland for a keynote address. I'd like to thank the panelists for their contribution. I'd like to thank Linda Fried, Dean Linda Fried, for the welcome. Alex Halliday, who couldn't stay, for co-sponsoring the event from the Earth Institute. I'd like to thank Jamie Kim and Leslie Ferreira from President Bollinger's office. And most important of all, I'd like to thank you for coming. Thank you very much.